Go ahead, sir. Thank you.
Okay. Good afternoon, everyone from UK here, and good evening to all the audiences, our pediatric audiences in the South Asia and Southeast Asia, mainly Nepal, India, Sri Lanka, Myanmar, and Cambodia. We welcome all of you to today's Hot Topics in Pediatrics.
HExN.
We hope you all find this session very useful and informative. It is our initiative to have a session on one pediatric subspecialty each time. So this webinar has been possible with the support of HExN Nepal UK, our UK-based Nepalese medical charity mainly for health education. My pediatrician colleagues at the James Cook University Hospital, South Tees Hospitals NHS Foundation Trust, Nepal Paediatric Society, and Myanmar Paediatric Society. We are hugely indebted to USP in India for publicizing and broadcasting this webinar to South and Southeast Asia. Our sincere thanks to the speakers and chairpersons for their valuable time and effort, and importantly, all of you in the audience for dialing in today. This session has been accredited by Royal College of Pediatrics and Child Health for 2 external CPD points. There are some rules today, like your microphones and cameras won't work with the live Zoom, but please ask in questions live in the chat box in that webinar. Time permitting, we will address as many questions as possible during the panel discussion at the end. Please do be patient with us if we experience any technical glitches on the way, but we will keep you updated. And most importantly, this is very important for us, please do not forget to fill up online evaluation form. This is very important for us as it helps us improve the webinar in coming days. So this is first of our series. We are planning to do one at least 2 monthly. So this time we have chosen pediatric endocrinology as a theme for today's webinar, and we have 2 brilliant speakers in this field. So our talks will be chaired by Dr. Krishna Bista. He is a senior consultant pediatrician at Kanti Children's Hospital, Nepal. He is currently the president of Nepal Paediatric Society, NEPAS, and a member of APPA Technical Advisory Group, Nepal. He is a member of National Immunization Advisory Committee and member of Breast Milk Promotion and Protection Committee to Government of Nepal. He has presented his research work nationally and internationally, and I'll hand over the mic to Dr. Bista. Over to you, Dr. Bista.
Thank you, Dr. Anil. First of all, I'd like to thank Dr. Anil and HExN Nepal and other friends from UK. Without their help, we will not be able to start this symposium. So we will try to continue periodically as soon as possible. So this is our first time and we may have some problems. Let us try to include all countries, not only UK, from Nepal, Myanmar, Sri Lanka, Bangladesh, India, or other countries. So it will be a Southeast Asia hot topics in pediatrics. So today we have 2 speakers. So I will introduce first speaker and then she will present, and next I will present and he will present the topics. The first topic is controversies in management of thyroid disorders in children, and it's my pleasure to introduce Dr. Ginny Birrell, a senior consultant pediatrician, the James Cook Hospital, UK. She qualified in 1990 from Newcastle University and after training has been working as a senior consultant pediatrician at the James Cook University Hospital since 2004. Her special interest is in pediatric diabetes, endocrinology and eating disorders in children. She is also active in teaching and training of both undergraduate and postgraduate students. She had a number of publications in peer-reviewed journals and various aspects of pediatric endocrinology. So it's my pleasure to introduce Ginny Birrell. It's up to you, Ginny Birrell.
Thank you very much. I will just get my talk. Thank you. So my aim is for the next 40 to 45 minutes to talk to you about some controversies in the management of thyroid disorders in children. The plan for my talk is I'm going to start by talking about congenital hypothyroidism. I'll cover some background of this and some basic physiology. I'll talk a little bit about the United Kingdom screening programme and then finish this area off with a case presentation. I'll then follow this by going to the opposite end and talk a little bit about thyrotoxicosis with an interesting case presentation, and then just to talk a little bit about the unusual presentations of thyrotoxicosis in the paediatric population. So to start with, when we start thinking about congenital hypothyroidism, for us, the incidence in the UK is between 1 in 3,500 and 1 in 4,000 live births. Although this incidence increases in various countries, and certainly within the Asian population, Native American population and Hispanic populations, it's thought to be more prevalent with an incidence of about 1 in 3,000. So it is a worldwide problem. And many of you will be aware of the clinical features that this can present with when it's not been diagnosed at birth, but gets picked up a little later on. And by then, the features of it can be very difficult to treat, and the neurological impairment which goes with it are not treatable. But to think about congenital hypothyroidism, that in itself is not a diagnosis, that is a symptom. And to think about the cause of it, we need to go back to our thyroid hormone physiology. And so for the next couple of slides, I'll just remind you about what happens with the thyroid gland. So the stimulation of the thyroid gland is controlled by the hypothalamo-pituitary axis and the secretion of thyroid stimulating hormone, TSH. This binds to a receptor on the thyroid gland. The thyroid gland manufactures a protein called thyroglobulin, which I've put down as TG on my slide. And thyroglobulin then has a tyrosine molecule attached to it. To continue with thyroid hormone synthesis, we need to take in dietary iodine, which is converted to iodide and taken up into the thyroid gland. Within the thyroid gland, the iodide binds to the tyrosine molecule on the thyroglobulin, and you get the formation of initially monoiodotyrosine, and then these coupled together to form diiodotyrosine. Secreted into the circulation, you'll either have triiodotyrosine, which would be an MIT and a DIT joined together, or you have two DIT joined together to form T4. And also the thyroid does secrete thyroglobulin. These circulate mainly bound to proteins, and at their target organs, they are released into the tissues to promote metabolism. Most of the T4 is then converted to T3, and that is the active form, which is most effective. So once we've thought about how the thyroid hormones are synthesized, we can then start to consider what happens in congenital hypothyroidism. And on this next slide, I've put stars against all the reasons why the thyroid gland may not work normally. In the UK, the commonest cause of thyroid hormone or congenital hypothyroidism is actually thyroid dysgenesis, where the thyroid gland itself doesn't form normally. So we had to think back to what happens in the development of the thyroid gland. Now it's formed in the floor of the primitive pharynx and then descends into the neck. About 80 to 85% of congenital hypothyroidism is caused by a problem within this process. There could be pure dysgenesis where no thyroid gland is formed at all. There could be hypoplasia where it's formed but it's very small. Or there may be problems with descent, so ectopic tissue is found in the neck but doesn't descend to the correct area. Females are more likely to be affected than males in a proportion of 2 to 1. And although not all the genes have been isolated, there is certainly a genetic component to this. And we know this as it's more common, for example, in trisomy 21. But also there are environmental causes which can cause this. Now, we may get secondary hypothyroidism where there's a problem established within the hypothalamo-pituitary axis and TSH is not produced. And again, that will present as congenital hypothyroidism. Very rarely, there's no receptor or there's a receptor problem, so the TSH has nowhere to bind. Worldwide, iodine deficiency is the commonest cause of congenital hypothyroidism. And this is more prevalent in some countries compared to others. The last area, big area within the UK population for causing congenital hypothyroidism is to do with the inborn errors of metabolism, and this accounts for 10 to 15%. This is where within the thyroid gland, there'd be either a failure to concentrate the iodide or an organification defect where the iodide cannot bind to the tyrosine molecule. Often this is associated with autosomal recessive single genes, and many of you will be aware of syndromes, for example, Pendred's, where there's an association with deafness. Lastly, but also very rarely, you may have thyroid hormone resistance peripherally. So this is an infant who has undiagnosed congenital hypothyroidism, and you'll notice some of the features which are well described in this condition. This infant is wasted. They often have poor feeding and poor weight gain. They are often constipated. They are hypotonic, and they are lethargic. And when you look closer at the face is puffy, has coarse features, and the infants often have a hoarse cry. Now, the condition that we most worry about is with developmental delay, as the brain needs thyroxine to develop normally. And often, by the time congenital hypothyroidism is evident clinically, the brain has been affected to a degree that starting thyroxine will not undo the damage that has been done. So I'm now going to talk a little bit about the UK screening programme for congenital hypothyroidism. Now, in the mid-1970s, there was talk about blood spot screening for TSH. And this was initially started piecemeal throughout the United Kingdom, but is now part of a national programme. Now, it's related to picking up a high level of TSH in the neonate's blood. And so therefore, it will only pick up primary hypothyroidism where there's a problem within the thyroid gland itself. Of the conditions that we pick up, approximately 90% are permanent, but 10% may be transient. The aim of our screening programme is to start babies on treatment by day 21. And the data for this is now nationally audited and collected. On day 5, all babies have a heel prick test. And this is where a capillary blood test is put onto a blot of paper and 4 spots are filled in and they're sent off to the regional laboratories. Now, the blood spot screening test not only picks up congenital hypothyroidism, but also screens for a number of other conditions, for example, cystic fibrosis, sickle cell disease, a number of inborn errors of metabolism, for example, PKU, MCAD, maple syrup urine disease, etc. But what we're going to concentrate today is the congenital hypothyroidism. So if a blood spot is analysed and the TSH is found to be greater than a 6, another spot on that same sample on the same test sheet is analysed. If it then lies between 8 and 20, it's determined to be indeterminate and a request for a repeat heel prick is asked for. If it's greater than 20, a positive result is confirmed. And then on the repeat blood spot, if the TSH is greater than 8, it's deemed positive. Now, there's much controversy about what should constitute positive. If we put the level too high, then we'll end up with some false negatives. If we put the level too low, we end up with false positives. And both of these can carry problems. So this is where we're currently working, and this has kind of been agreed on a national basis, but certainly amongst paediatric endocrinologists within the UK, not everyone agrees with the levels that have been set. So if there is a positive test, it's normally available by about day 10 or 11. However, if the test has had to be repeated, then it may be day 20 before this comes up as positive. As soon as positive test is identified, the laboratory will notify a named paediatrician and the patient's primary care practitioner. And every district general hospital and tertiary hospital in the UK has a named paediatrician for congenital hypothyroidism. The GP will contact the family and ask them to attend their local hospital urgently that day. Once they arrive at the hospital, they have a full assessment with a history, weight, height, and medical examination. And then venous blood is checked for a TSH, a T4, and a T3. Now, in the hospital I work, we're very fortunate that we get these results back within 2 hours, but in other hospitals, it may take a little longer. So if the result is not available, we would recommend commencing thyroxine straight away, but I'm very fortunate in my hospital that we can wait for that result, and we commence thyroxine at 10 micrograms per kilogram per day. If we've confirmed congenital hypothyroidism, following this initial appointment, we'll see them maybe 10 days later, and then 3 weeks later, and then another 4 weeks, another 6 weeks, and then 3 monthly for the first 1 year of life. And depending on how stable they are, we may then spread that out to 4 monthly in the first, in the second and third decades, and then to 6 monthly once the child is kind of reached 4 or 5 years of age. So you can see that getting a positive test leads to a number of visits to hospital, and at each hospital visit, we will check a height and a weight, we'll check a medical history, and we'll perform a TSH, T4, and T3 to confirm that our treatment is within the right range. So I'd now like to share with you patient A, who's a baby who was referred to me when he was 11 years of age. The pregnancy had been normal, and he was born by a normal vaginal delivery. There were no issues at birth, and he was breastfed from birth. We were notified by the laboratory that he'd had a positive test, and that came through to us at 11 days of age. He was seen that day, and the history and examination were unremarkable. We checked his bloods, and they revealed a TSH of 34, a free T4 of 16, and a free T3 of 5.6. So herein lies the difficulty that we have. The TSH, no doubt, is elevated, but both the T4 and the T3 are sitting in the normal range. So do we treat this baby, or do we wait and see? Now, I personally get a bit nervous about TSHs sitting above 30. And so therefore, I decided to commence this baby on thyroxine. Now, one of the things that I'm very clear about with my babies that I look after is that we have thyroxine tablets available to us, but we also have thyroxine suspensions coming as either 25, 50, or 100 micrograms in 5 mils. When we first were presented with the idea of having thyroxine solution, we thought this was fantastic. So it's so much easier to give to babies. However, I have had numerous babies come through to the department who are on the wrong strength of medication for the amount that they are giving, as parents get used to drawing up a quantity of medication as opposed to a dose. So I was having babies who I felt were on 5 mils of 25 micrograms per mil, and 25 micrograms, and they'd come in on a different strength and be getting a completely different dose. And so therefore I've now changed, and I only give thyroxine tablets, and these are easily crushable, and we can change the doses by crushing them and dissolving them if need be. So this baby was started on thyroxine 37.5 micrograms per day. It was a borderline case, and I discussed this with the family, the risks and benefits of treating against not treating. and we did elect to treat. I saw the family as I'd planned on a very regular basis. And at 6 months of age, I arranged for an ultrasound scan of the baby's neck. And this showed a normal looking thyroid gland. At 3 years of age, the baby was still on the same dose of thyroxine, 37.5 micrograms daily, and the blood tests had always been in range. So at this stage, we decided we would try a trial off medication. And off treatment, the bloods remained normal, thus confirming that either this was transient hypothyroidism, or it was just hyperthyrotroponemia, a raised isolated TSH that didn't need treatment at all. What we're really wanting to make sure we pick up are the permanent hypothyroidisms and those with significant hypothyroidism that's going to affect their brain growth in the first 2 to 3 years of life. Permanent hypothyroidism is much more likely with a very high TSH at presentation, along with a low T4 and T3. We now routinely ultrasound all our babies at between 3 and 6 months of age, and if there's an absent ectopic or small thyroid gland, again, it's much more likely to be permanent hypothyroidism. And lastly, looking at how easy it is to treat and what happens with our blood tests over time. And we would expect the dose of thyroxine to increase over time and with age. And again, if this happens, it would suggest that we are dealing with permanent hypothyroidism. All our families are counselled as to whether we think it's transient or permanent. And we counsel them all that at the age of 3, we will offer a trial off treatment if it's deemed appropriate. Certainly, I advise parents where the TSH is very high and the thyroid gland is absent that I wouldn't see a benefit in coming off treatment. But if they wanted to, a baby or a child of 3 years of age will not suffer harm by going without thyroxine for 6 to 8 weeks and testing what happens. And so if we come back to that first baby, yes, the TSH was high and it was probably hyperthyrotroponemia. However, at 34, I wasn't happy to wait and see, and the parents agreed and we treated that baby. Other people may have elected to wait to see what was happening, to follow the thyroid function over every 3 to 4 weeks and see whether the TSH was going up or coming down. So I think this really highlights some of the pros and some of the cons of having a national screening programme. Certainly with regard to the pros, we are able to pick up and treat early hypothyroidism before the damage occurs. Our aim is to prevent permanent damage, and congenital hypothyroidism screening certainly fits all the criteria you would have for a screening programme. It is accessible, it's cost effective, it picks up a condition before its effects are really apparent, and it prevents those effects becoming more apparent. However, there are some cons to this. We certainly overtreat some babies, and my case A, you may argue, was one of those. We then subject these parents to unnecessary and repeated hospital visits, and we subject babies to maybe unnecessary and repeated blood tests, and give unneeded medication to babies. This also generates a large degree of parental anxiety. So we do have to try and sort out those babies that we treat and don't treat. And as I've said before, there are no clear guidelines as to what level we should institute treatment. And that's really down to the individual clinician's knowledge, experience, but also what the parents might want. When we think about screening programs, what is good about this program is that it does capture all babies. And within the UK, the blood spot screening program is very well established and very much taken up by families. But for this system to work, you need to have a centralised laboratory and centralised funding. And where this becomes harder to implement would be in countries with a large rural base, where babies are born in primary healthcare units away from hospitals with easy investigation and treatment. And so therefore instituting national screening programs have been very difficult throughout the world. I'm next going to cover thyrotoxicosis and talk a little bit about that. So as you'll be aware, thyrotoxicosis is an overactive thyroid gland. It most commonly presents in the UK as Graves' disease, which is an autoimmune condition whereby there are antibodies produced to the TSH receptor and the thyroid gland is switched on constantly. However, we also see it with Hashimoto's thyroiditis, which is an inflammatory but also autoimmune process affecting the thyroid gland, where often we have hypothyroidism or thyrotoxicosis, but as the disease burns itself out, many of these people then become hypothyroid. So for all thyrotoxicosis, it's more common in females than males, and more common in our older patients, so teenagers and beyond. And when it presents in teenagers and beyond, the clinical features are fairly straightforward. So I'd like to talk to you now about patient B and tell you the story of him. So he presented to us at 3 years of age. Now, clearly, as I'm talking about thyrotoxicosis, you'll appreciate that there isn't a diagnostic dilemma in that we know what the answer is, but it did take us a little while to get to that answer. So he presented to his primary care doctor with his parents saying that he was an anxious little boy. He was very fidgety and jittery, always on the go, never settling down. He'd lost some weight, and the parents had noticed that they could feel his heart racing when they put their hands on his chest. And he was also short of breath. The GP saw them in primary care and confirmed that his heart was racing, and also thought that there was something unusual with his heart examination, so referred him through to the acute paediatricians that day. So he was seen in hospital, and he really was very fidgety. He was tachycardic with a heart rate of 135, and his precordium was very active. There was a thrill over his chest, and he had a loud pansystolic murmur heard all over the chest. He was mildly tachypneic with a respiratory rate of 18 per minute. He had no hepatosplenomegaly, and there was no peripheral edema. In view of the cardiac findings, an urgent echocardiogram was arranged that day. This showed that his heart was very hyperdynamic. He had significant mitral regurgitation. He had a degree of tricuspid regurgitation, and he had reduced left ventricular function. So at that stage, he was diagnosed with mitral regurgitation with mild heart failure, and the plan was made to commence him on beta blockers and diuretics. And an urgent referral was made to our tertiary cardiac unit, which is based by road about 50 miles from our hospital. So the patient and family were sent down to our pharmacy to collect their prescriptions. And as they were down collecting their prescriptions, the blood results were phoned back to our unit. These revealed a TSH of less than 0.01, a free T4 of greater than 100, and a T3 of 22. All features telling us that this boy was incredibly thyrotoxic. Fortunately, we had the mobile phone number of the family, and we called them as they were in the pharmacy and said, "Can you come back to the paediatric unit?" Now, with the benefit of hindsight, I was actually on call that evening when he came back, and I already had these blood results to hand. However, looking at him, he was blatantly thyrotoxic to me. Although I do wonder whether I would have been so on the ball if I hadn't had the blood results and knew what was going on. He had marked proptosis. He had a moderate goiter, which had a thrill, a bruit, and he had a significant tremor with sweatiness. So now we had a boy who had mitral regurgitation secondary to thyrotoxicosis. It's interesting with patient B because I think it's always easy when we know the answer and we have our results back. However, it was all there if we had looked to see it. There was a very distracting finding, which was the murmur and the heart issues. And in fact, when I reviewed his initial clerking in his hospital notes, there was a comment that mum wondered about the thyroid because a member of her family had had an overactive thyroid gland. But this was completely lost when people picked up the murmur and started concentrating on the cardiac issues. This boy would have ended up having his heart treated before anything had been found out about the thyroid if the blood tests had not been done. And there would have been risks of worsening heart failure and even death before he could have been diagnosed. So the message here is that you won't find thyroid disease unless you look for it. Now, in my experience with the thyrotoxicosis, I have seen it present as a number of different conditions. I've now seen 3 children who presented with heart failure. This first boy who had a hyperdynamic circulation associated with mitral valve issues. I've had 2 children who presented with AV malformations, which have led to heart failure, one of whom was having brain scans to see whether that's where the malformation was, and another who was still under investigation by the cardiac unit. I've seen a 3-year-old who'd been in a gastroenterology clinic for a year with diarrhea and faltering growth before she walked into the endocrine clinic having had some bloods done, and she looked obviously thyrotoxic to me, but again, with the benefit of having those bloods to hand. I've seen them present to the psychiatry department with ADHD, attention deficit hyperactivity disorder, and behaviour issues, and certainly with school exclusions. I've seen children with chronic fatigue who've been looked after in a chronic fatigue clinic, where people have been worried more about hypothyroidism than hyperthyroidism, and have screened and been surprised that thyrotoxicosis can cause chronic fatigue. One of my areas of special interest is with eating disorders, and I've certainly taken 1 girl out of my eating disorder service who was found to have thyrotoxicosis as opposed to anorexia nervosa. I've looked after some twins who've had thyrotoxicosis. One presented at the age of 8 and her sibling came at the age of 9. The 8-year-old was picked up because she had poor concentration and poor schoolwork. And eventually someone noticed a swelling in her neck and referred her through to us. These children may present as in crisis or as thyroid storm. And although I've not looked after this young lady, there is a little girl who is having an endoscopy, and we've got a very interesting anaesthetic chart showing her thyroid storm, actually while she was on the table, with a rapid rise in blood pressure and in pulse rate. And in fact, her problem wasn't esophageal reflux at all, it was hypothyroidism, which had not been picked up. And then lastly, we might see patients with the classical features that we'll read about in the textbooks of jitteriness, sweatiness, a goiter, eye signs. And in my experience, the older the young person is, the more likely they are to have classical features. So what can we do about this? I certainly spend my time looking at patients' necks. I'm always looking for goiters, and I don't know whether that's good or bad. I have a general paediatric workload, and I've diagnosed hypothyroidism in 2 mothers who've come through to the clinic with their children. And I've commented, have you always had that swelling in your neck? And they've gone away and got that looked into and been diagnosed with underactive thyroid glands. So I certainly look at necks a lot. We're now very fortunate that parents mostly carry smartphones and have lots and lots and lots of photographs of their children. And so looking at how a young person's appearance has changed over time can be quite valuable. Parents often don't notice the change in appearance if the child is getting more proptosis, because things happen very gradually. So asking for photos from 3, 6 or 12 months ago can really demonstrate how a child's appearance has changed. I always find it quite interesting asking a young person who's got thyrotoxicosis to write something out for me with pen and paper, and then to compare this to their work previously about a year ago, and then hopefully to keep that bit of paper and to compare things a year down the line when they're on treatment. And there's no doubt that young people with thyrotoxicosis become much messier with their handwriting, and struggle a lot with concentrating with their schoolwork. As I've said, the eye signs can be quite apparent, but you do have to look for them. Feeling for a pulse, checking for a blood pressure, and doing a cardiac examination. And if you find a murmur, thinking to yourself, what might be the cause of this, as opposed to the heart being the primary problem. Looking for a tremor, and again, that may not be obvious, but watching a child in clinic and seeing how fidgety they are. And lastly, looking for sweating. So if we do diagnose thyrotoxicosis, the first thing we want to do is to get them on treatment. And in the UK, our treatment is normally focused around stopping thyroxine production and managing the symptoms. My first line of treatment is carbimazole, and this works by decreasing the uptake and the concentration of iodine by the thyroid gland and leads to reduced formation of diiodothyroxine. PTU, propylthiouracil, works in a similar way in that it inhibits iodine and peroxidase interaction and leads to less production of thyroxine. But it has a second effect as well, which is it interferes with conversion of T4 to T3 in the periphery. So therefore, you may get a quicker response with PTU. The difficulty with both of these medicines is that they reduce formation of thyroxine. But if the thyroid gland is already full of thyroxine ready to be secreted, then there's going to be a lag between starting treatment and starting to get resolution of symptoms. So therefore, we also use beta blockers to control the symptoms. And in my practice, we use propranolol. I do refer all my patients through for an ophthalmological assessment, and viscous tears are very useful for protecting the eyes. But in the long run, we may need to consider whether a patient needs to have definitive treatment. And this could be undertaken with either radioiodine therapy or surgery, both of which carry some risks and some complications. So if we go back to patient B, who presented to me at 3 years of age, he was very compliant with his medication, however, seemed to be fairly resistant to medical treatment. His heart failure improved quite quickly. He was started on propranolol and diuretics, as well as carbimazole. And his mitral regurgitation by about 4 months of treatment had completely gone away. However, he was on carbimazole, and one of the side effects of this is agranulocytosis, a reduced neutrophil count. Now, we have a protocol in place that every child who's on carbimazole, every time they get a fever, they need to attend hospital to get a blood count checked to ensure they're not neutropenic, because we don't want to miss an episode of febrile neutropenia. Now, 3-year-olds spend a lot of their time in nursery, mixing with other children and sharing viruses. And so therefore, our patient got repeated episodes of high temperature and was coming to hospital every 4 to 6 weeks to get bloods checked. He never became neutropenic, but it became a worrying risk and also quite difficult for him because he really didn't like having his blood tests done. And we were having to check his blood for monitoring his thyroid, but then also repeated full blood counts. Despite regular treatment, it took him 12 months to become euthyroid. And once he was about 4 years of age, we thought about some definitive treatment as his thyroid-stimulating antibodies were positive, indicating it was Graves', and the levels remained very high. Now, in the past, we used to refer lots of our children through for radioiodine, and it seems that we go through waves of either having a lot of radioiodine chosen or a lot of thyroid surgery. We currently have an excellent thyroid surgeon who's based in our tertiary hospital, and he performs all thyroid surgery on all children within the northern region, which means that he has got a large amount of expertise with this. This leads to him having a much lower complication rate. And our patient went to the tertiary centre and spoke with both the experts within radioiodine and also the surgeon. I always ask them to meet both specialists to hear the pros and cons of each one, and then they can choose which they wanted to go with. Interestingly, I think that I would choose to have a drink rather than to have my throat cut, but currently most of my patients are persuaded by the surgeons that surgery is the best option. And as our surgeon has a very low rate of complications, mainly recurrent laryngeal nerve damage and parathyroid damage, they are often choosing that route. He had an uncomplicated thyroidectomy at age 5 years and is now on thyroxine. He's growing, he gets his blood checked every 6 months, and he's very well. So that was a very good outcome for him. So I'd like just to finish by summarising that thyroid problems are very common. They are only easy to diagnose if you think of them. And so if I can encourage you to start looking at patients next as they come through the door, that might be a good start. And with congenital hypothyroidism, the screening programme, the aim is to start treatment before it's too late. You need to consider if there's unexplained developmental delay. And in the UK, we need to be aware that our screening programme only detects primary congenital hypothyroidism, not secondary. And so therefore, thyroid function tests should form a basic part of any child who presents with prolonged jaundice, developmental delay, or any concerns with their growth and development. Thank you very much for your time. I've said I could take questions here, but I think that we are leaving questions to the end, so I'll hand things back to the chair.
Yeah,
Thank you.
Jenny, we have some time before the next session. Will you be okay to answer a few questions? There are quite a few questions just come up.
Yes, I'm very happy to answer some questions. I can't see anything, so are you going to channel those to me?
Yeah. I'm just going to channel it through you. The first question is, I don't know from where. Is it mandatory to check FT3 level every time? And FT4 and TSS level enough?
So I check the T3 at diagnosis and for a couple of times afterwards. I check TSH and T4 every time after that. Our laboratories would choose just to do a TSH, but that doesn't tell the whole story. And certainly if there's poor compliance with medication, you can end up with a TSH that's very high, but a T4 that's within the normal range. And so therefore, for that reason, since we do have poor compliance with many of our patients, I prefer to check a TSH and a T4 before I make a decision about altering treatment.
Yeah, that's fine. And there is another one. I don't know from where, but they said that here we send TSS after 48 hours of life since patients are being discharged after 72 hours. So what should be upper level of TSS in order to suspect congenital hypothyroidism at 48 to 72 hours? In resource limited, I haven't finished it. Yeah, in resource limited setting, is it cost effective to send TSS of all the babies or in some specific conditions?
I think that's a really difficult question to answer because ours are based on levels done at 5 days of age. We know that TSH is high at birth and it drops, which is why, again, those ones that are borderline at 5 days get a repeat. And there's debate in the UK about what the cutoff should be. So I'm afraid, I think if you've got a very high TSH above 25 or 30 at 48 hours, then it's going to be worth keeping an eye on that baby. But I don't know that I can give you an answer about what would be a level at 48 hours. I would also say that most congenital hypothyroidism that we see, there are no risk factors for it. So I think it's very hard to try and screen out which babies you would test for more often than others. My concern would be that babies that you think there's a problem are more likely to have secondary hypothyroidism for those who, for example, who pick up with hypoglycemia or other issues at birth. And so a TSH isn't going to be good enough to screen those. So to me, it should be a universal test, but I accept that that's not going to be possible everywhere.
Yeah. And we still have some time. There is third question. Hi, at adolescence, do you transfer these children's care to adult endocrine or GP? As a GP, I manage most hypothyroidism unless when they are on high dose, preconceptions, etc., then refer to secondary care. Anything we GPs need to be aware on managing these patients differently? I think this is from here, one of the GPs from UK.
Yeah, so I think that's a very, very fair question. I tend to transfer my young people once they reach 16 years of age. I think that my job for the first few years of life are to ensure concordance and to discuss things with the parents. But once they reach 12, 13, 14 years of age, my job is to educate the young person about their thyroid. And the only key thing that I say to the girls is that they need to increase their thyroid dose, their thyroxine dose, when they become pregnant. As preconception, it's very important that they have, or periconception, they have higher thyroid hormone levels in their bodies. So yes, I tend to transition beyond 16 because by that stage, most young people are more independent on their own care. And I spend those last couple of years talking to them about their condition, why they need to take their thyroxine, and try and give them a bit more control over their condition. But yes, it does get transferred to our GPs. I don't transfer these to endocrinologists unless there's something different going on.
Yeah, Jeannie, a lot of questions are coming up now. I'll go for one more. Is that okay? Before
yes, that's fine. Yep.
We're going to discuss again in panel discussion anyway. Please, can you comment on neonatal thyrotoxicosis and thyroid stone?
Yes, so neonatal thyrotoxicosis, I have to say, would be a talk in itself. It's typically caused by a mother who's got circulating antibodies, thyroid receptor antibodies, which cross the placenta. And so the babies are born with an activated thyroid gland. So that often presents at 24, 48 hours of age with babies who are jittery, tachycardic, and can be very, very unwell. I would like to think that we screen for this in the UK, but we're not very good at doing that. And the problem is that many women who've had Graves' disease may well have had thyroidectomies and be on thyroxine. And so therefore people forget they may still have circulating antibodies. But typically it presents with tachycardia, but that can go on to cause heart failure, vomiting, diarrhea, weight loss, jaundice, all sorts of problems in the neonatal period, which can be very difficult to treat.
I think I'll have a last question. Is this what is that? When should we repeat TFT when it is borderline at first screening?
Yes, that's a good question. It depends on how borderline it is. I think that we do far too many thyroid function tests in the UK. If the TSH is less than 10 and the free T4 is normal, I would probably do it a month down the line just to check that things are coming down. Once you get above 10, I still think every 2 to 4 weeks would be soon enough because you need to be looking for a big change for things to occur. But the key is making sure that you've got plenty of circulating thyroxine. And if there's any doubt at all that the free T4 levels or T3 levels are dropping, then I would repeat more often or more likely start on some treatment.
Dr. Bista, do you have any questions from Nepalese perspective?
No, I don't have. There are maybe some friends who are working in endocrinology.
Yeah. Okay.
There is no any questions here.
Okay, shall we go to the next session? Thank you so much, Jeannie. It's been a very, very useful, very informative talk.
You're welcome.
Hope everybody enjoyed. Yeah. Yeah, you just hang around on that because we have the panel discussion at the end. Yeah.
Thanks, Jeannie, for your excellent presentation. So now it's my pleasure to present our second speaker. He is Dr. Kishore Sajjan Raj, consultant pediatrician, University Hospital of North Tees, UK, and he is presenting on challenges in diagnosis and management of children with congenital adrenal hyperplasia. So Dr. Kishore is a consultant pediatrician at North Tees and Art Laypool Hospitals, NHS Foundation Trust. After coming to UK, he worked in Barta, London. He underwent pediatric training in Newcastle and was appointed as consultant in 2017. His specialist interest is in diabetes and endocrinology and has been guest speaker on a number of meetings. Dr. Kishore, it's up to you.
Thank you, Dr. Bista. I'll just load my presentation. Can you all see the presentation?
Yes, Kishore, we can see.
Yeah.
Thank you. So I'll be talking to all of you about congenital adrenal hyperplasia, which often presents at a time when usually the most junior of our colleagues are around, and sometimes they give us a call and we need to guide them to manage this particularly important diagnosis which presents in babies. So The agenda that I have for this talk is we'll discuss a little bit about normal development and physiology of adrenal glands and the gonads. And then we'll discuss a little bit about steroidogenesis. And we'll discuss a little bit about 21 hydroxylase deficiency, which is the most common type of congenital adrenal hyperplasia. And then neonatal screening wherever it is conducted. And then a case study, and then how diagnosis is made and management, including acute and ongoing management. And we'll discuss a little bit about new trends, non-classical CAH, and some other forms of CAH. So normal development and physiology. We all know babies need to have an appropriate genotype for their gonadal sex to be determined. And that then determines the phenotype that the baby displays. Obviously, there could be some chromosomal abnormalities and endocrine abnormalities affecting that phenotype. But whatever is the phenotype, if it does not require addressing at the time of neonatal age group, then that goes on to determine the social sexual role that the individual takes on in the future. So if we just discuss what happens in the fetal stage, we all of us are destined to become females. If we have Y chromosome, then we become males. So we need to have Y chromosome, and particularly the SRY gene and the SRY protein, so that that can act on the bipotential gonad for it to be then diverted from, rather than from becoming the ovary, to become the testes. And the testes then goes on to display a couple of cells, which is Leydig cells and the Sertoli cells. And not just that, but we would need to have receptors on the Leydig cells for the HCG coming from the placenta to then produce androgens. But at the same time, the testes, which has got the Sertoli cells, also makes the Mullerian inhibiting factor, so that all the Mullerian ducts are regressed in a genotypically male child. At the same time, the testosterone coming from the Leydig cells then goes on to get converted to dihydrotestosterone in the presence of 5-alpha reductase. Of course, we do need the receptors present so that the masculinization of the external genitalia of that male, genotypically male child happens. So if there is any problem anywhere in this whole process, there could be issues with sexual development, and there could be disorders of sexual development happening. What we also see is in the initial stages, the external genitalia are indifferent, and then with the help of the androgen receptors and the dihydrotestosterone, what you find is in a genotypically male child, it then goes on to develop the phallus as well as the scrotum, and of course the testes then descend into the scrotum. At the same time, what you see in females, you see that the development of the clitoris as well as the labia minora and the labia majora happens, but these tissues are again androgen sensitive. So if there is too much of androgen available in the baby's genotypically female baby, then these tissues can also get stimulated and develop into a male type phenotype. If we go on to look at adrenal development, what we see is adrenal development starts from around 4 to 6 weeks of fetal life. What you have is the adrenal medulla, which comes from the ectoderm, and the adrenal cortex, which comes from the mesoderm, joined together. And then gradually by 9 weeks of age, you have a adrenal cortex which develops, and then subsequently keeps developing until birth to produce 2 distinct layers, the zona glomerulosa and the zona fasciculata. And then that eventually by 3 years of age also displays another layer called zona reticularis. As you might know, these 3 layers produce 3 different hormones, but in the time of birth, the zona fasciculata can also produce the adrenal androgens. So it's not just at 3 years of age that the adrenals can produce androgens, but also before, despite not clearly displaying a separate layer of zona reticularis. So in terms of physiology, all of you might be already aware that 3 layers in the cortex, and then you have the medulla. In the cortex, zona glomerulosa is the layer which produces the aldosterone, and this is regulated by the renin-aldosterone-angiotensin system, and the zona fasciculata and the zona reticularis together produces the cortisol and the androgens, and these are primarily under the control of the ACTH. And of course, the adrenal medulla produces the catecholamines, as we know. So going to the steroidogenesis, it is important to know the steroidogenic pathway to some extent. Perhaps it's difficult to remember all the steps that are involved, but it is important to know to have some understanding of this for us to understand what is happening in a particular baby. So if I take you through this, what you have is the cholesterol molecule. And the cholesterol molecule is the precursor of all steroid hormones, both in the adrenal as well as the gonadal tissue. So without cholesterol, we won't be able to make any steroid hormones. So say babies with Smith-Lemli-Opitz syndrome may have features similar to congenital adrenal hyperplasia, to the extent that it is now considered as one of the forms of congenital adrenal hyperplasia. Now, once cholesterol is available, then it requires a series of enzymes for it to then convert it to aldosterone or cortisol or the adrenal androgens, which, as you see through the aromatase enzyme, can be switched to estrogens as well. But for the cholesterol to enter the adrenal mitochondrial tissue, you need the CYP11A gene, but also the presence of the steroidogenic acute regulatory protein. Otherwise, the cholesterol will not enter the mitochondria, and hence you will have the similar features. So of particular importance for our talk today is the 21-hydroxylase enzyme, which is deficient in the 21-hydroxylase deficiency form of CAH. And what you have in any metabolic pathway is, of course, if there is an enzyme defect, you have reduced production of the downstream chemicals and too much availability of substrates above it. And of course, if you look at this diagram, what you see is 21-hydroxylase affects the aldosterone pathway as well as the cholesterol pathway, but certainly not the adrenal androgenic pathway. We will be coming back to this steroidogenic pathway again, but this is just a quick overview of what is happening within the adrenal cortex. A word about the placental-fetal adrenal unit. The fetus and the placenta work like a team, and the reason for working as a team is because the fetal adrenal lacks this enzyme called the 3-beta-hydroxysteroid dehydrogenase. So without this, as you know, all 3 pathways will get affected because it's one of the most proximal enzymes within this pathway. And without this, the fetal adrenal cannot produce any steroid hormone. So it does captures the cholesterol, as we discussed, and then it produces the pregnenolone. And then what happens is it uses sulfatase enzyme to sulfatize these precursor molecule, and they go across the placenta and then get acted upon by 3-beta-hydroxysteroid, which is present in the placenta. And eventually that gets reverted back into the fetal adrenaline, where aldosterone and cortisols are produced. But once these are produced, as well as the DHA, they can go back to the placental circulation, and they can get converted from androstenedione to estriol. The reason to know this is sometimes low estriol concentration in mum serum could be a hallmark of a problem with fetal adrenal tissue, and that sometimes may come across to you if the obstetricians have checked that in the mum. So if you know this, then you know why the estriol might be reduced. So talking about congenital adrenal hyperplasia, we have lots of different types, but majority of them are as listed there. These are autosomal recessive disorders of adrenal steroidogenesis. As we discussed, 21-hydroxylase deficiency is the most common type. And then, of course, there are other rarer types like 11-beta-hydroxylase and 17-alpha-hydroxylase deficiency. The 3-beta hydroxysteroid dehydrogenase deficiency is much more rarer than that. And of course, we have the star protein deficiency, as we discussed, which requires the cholesterol for it to enter the mitochondria. Overall, CAH has got a prevalence rate of 1 in 14 to 18,000 live births. In some population, it's much more common. In terms of what is happening with CAH, basically there is enzyme deficiency, as we discussed. So there is reduction in end products, accumulation of precursors, and that causes reduced feedback mechanism to the pituitary, and hence the ACTH production is increased. And of course, that leads to the pathway redirection towards producing a lot of adrenal androgens, and that becomes the main problem, particularly if the baby is genotypically female. So this is the pathway which I was just discussing, which produces cortisol normally through this pathway, and the cortisol in its presence causes negative feedback on the hypothalamus and the anterior pituitary. But of course, if there is enzyme defect in the adrenal cortex, not much cortisol is produced, and hence the negative feedback is lost, and hence the ACTH goes up, and it tries to stimulate the adrenal. Hence the adrenal becomes hyperplastic, hence the name congenital adrenal hyperplasia. But added problem is that the adrenal gland also produces androgens, and that becomes a particular problem in a genotypically female child. In terms of 21 hydroxylase deficiency, 95% of CAH patients have got this. The gene is on the chromosome 6p short arm. It's closely linked to the HLA genes, and that determines the allelic variation, and hence within the same family, you may have children who have got classic as well as non-classic forms of CAH. So these are two types of phenotype which the 21 hydroxylase which displays. The classic one is severe, but it can also present as a simple virilizing form in 1/4 of the patients, but much more commonly in 3/4 of the patients, it is salt losing type, which may require urgent management. It is rarer compared to the non-classic phenotype, which is milder and is of late onset form. The incidence is, as you see, 1 in 500 to 1 in 1,000. But the phenotype is usually not picked up appropriately, and hence the incidence that you see is probably an underestimate. Obviously, in areas where there are high consanguineous relationships, you see a higher incidence there. It does cause late onset virilization, and that's sometimes how it comes to light. In terms of the enzyme disorder, the 21 hydroxylase deficiency, as we discussed, happens between the progesterone and deoxycorticosterone pathway in the aldosterone pathway, and the pregnenolone and the 17-hydroxyprogesterone gets converted, but it does not further get converted into 11-deoxycortisol and cortisol. So that's where the defect is, and hence you have reduced aldosterone and reduced cortisol. Of course, aldosterone is controlled by the renin-angiotensin in aldosterone system, but the cortisol then goes in its absence, reduces the feedback on the pituitary, and hence the ACTH goes up. And what you see is these two increase in their amounts, and then the pathway gets redirected. Of course, it's much more easier to remember with a slide like this, but sometimes it's difficult for us to explain all of this to a very worried parent. And I often use the analogy which is given to me by one of our tertiary endocrinologists, and which is to use the 3-lane motorway analogy. What you see here is 3 lanes in the motorway, and you see 2 lanes are blocked because there is an accident. So if you assume this lane is the aldosterone lane, this lane is the cortisol lane, there's an enzyme defect and no traffic can go via this. So all the traffic gets rediverted to the 3rd lane, and what you have is lack of aldosterone and cortisol and a lot of androgens coming out through the adrenal gland. So how does it present? So in females, it presents with enlarged clitoris, partly fused in rugose labia majora, which looks like a scrotum, And then obviously what you also see is a common urogenital sinus. So you don't see two sinuses in that genital area. So it can be easily mistaken for a male child with an inexperienced examiner. And of course, what you don't see here is a palpable gonad within those labioscrotal folds. These babies have normal internal female organs because there is no Mullerian inhibiting factor, because the baby is genotypically female, and hence there is no Y chromosome. And as we discussed in the previous slides, you need the Y chromosome for you to go on to develop testes. And then, of course, you develop the anti-Mullerian hormone, which causes Mullerian structure regression. So that is not there, and hence internal female organs are preserved. But as we discussed, the external genitalia is still androgen responsive, and hence it looks quite ambiguous. These babies are usually identified early because of the same reason that they have ambiguous genitalia, rather than going on to develop salt-losing crisis. So they are protected, and they often don't have to pay a price by losing their life, whereas male babies do sometimes and many times have to pay that price, and that is clearly reflected in research studies. So you'll have less representation of male babies within any of the observation data that you get. Again, ambiguous genitalia does not come as one end or the other end. It comes as a spectrum, and Prader's scale is very good. And I recommend if you see a baby with ambiguous genitalia, use this scale. It's freely available on the internet for you to note it down as to what exactly you see, so that you are discussing with a tertiary endocrinologist over the phone, and you are able to describe what you see much more clearly. What you see here is the normal female genitalia at one end and normal male genitalia at the other end, and the 5 stages of virilization of the female external genitalia. As you see, there are 2 sinuses here. One is the urethral sinus, and the other is the vaginal opening. What you gradually see is they fuse together, and eventually you have one urogenital sinus. Of course, you also have externally clitoris, which is getting hypertrophied, and what you see is what appears to be a penis, which in fact it is not. What you wouldn't see is gonads palpable within those labioscrotal sacs. So in male babies, what you may not see is any signs, or you may just see that the baby is absolutely well. Subtle signs like hyperpigmentation is much more easily picked up in Caucasian babies who have lighter skin tone, but compared to Asian babies who have got a darker skin tone, it's much more difficult to pick up. What you would see is potentially a possible penile enlargement, and that might sometimes we might have junior colleagues asking us if it's abnormal, and sometimes that could be the trigger of further investigations. They are very often present with salt-losing crises, but certainly not before 7 days of age, and it will be very, very rare for us to see any baby presenting before 7 days of life. That is to do with the relative resistance to mineralocorticoids anyways that babies have in the initial phase, as well as the fact that they are initially oliguric and then subsequently polyuric, and it takes that amount of time for them to present like that. And when they do present, they present with typical signs of adrenal insufficiency, including emesis, weight loss, lethargy, dehydration, and electrolyte imbalance. So in terms of neonatal screening, we don't have much experience because it's not practiced in UK. As you heard from Dr. Birrell's talk, we do have neonatal screening program, but this is currently not included in that. And the aim of this screening program, wherever it's practiced, and it is practiced in many countries, particularly the United States of America, the idea is to reduce the morbidity and mortality of for male babies, because female babies will get picked up at birth with ambiguous genitalia. They do immunoassay initially, but it has got high sensitivity and low specificity. Hence, you get a lot of false positive. And if that is the result, then the second line testing is done, and that has got a higher specificity through the liquid chromatography method. Reference ranges are available, which are linked to the gestational age and birth weight of the baby. But sometimes what you get is a positive screening result, and then you do baseline tests in those countries. And if they are done, they should be done about over the age of 48 hours for the reasons that in the first 48 hours, the 17 OHP is invariably going to be high, and it will falsely tell you that it is a problem. Though we should draw some caution in babies who are sick because their hypothalamic pituitary adrenal axis is switched on to protect them, and in them you could falsely label them to have CAH instead. Obviously, one of the differentials, the way CAH presents is sepsis, so these are sick babies. So you should have some level of caution there in terms of interpretation. Obviously, preterm babies may display higher 17-OHP levels. If you do get those which are equivocal and you don't know what you need to do, then there is a cosintropin stimulation test available. It's similar to your ACTH test. You can do 0, 30, and 60 minutes cortisol and 17-OHP. Cortisol levels are debatable there, but generally above 500 would be classed as a pass there. The 17-OHP can then help you determine which problem you're dealing with. This is a nice chart, a graph looking at how you could interpret the baseline levels as well as the stimulated levels at 60 minutes. And what you see is a linear distribution in which both are high, both the stimulated and the baseline in those who have classic congenital adrenal hyperplasia. Those who have non-classical have much lesser, and those who have who are carriers, they lie somewhere here. And those who are heterozygote carriers would then lie within this huge clump there. So it could be useful to determine, but sometimes gray area territory results are always there to deal with. We'll now discuss a case story. Obviously, the child's name is changed, so we'll name him as Michael here for this presentation. So he was referred by the community midwife at 19 days of age. He was a term infant who was not gaining weight. That was the main concern. And on the day of the assessment by midwife, he was not looking well. He looked pale. He had lost around 10% of birth weight, and at 19 days of age, with his current weight of 3.16. On assessment and discussion with mom, he appeared to be feeding really well, but he was still getting more and more lethargic. He was having heavy wet nappies, and on examination, he looked quite lethargic. Certainly, a thyroid problem would come to your mind if you looked at him. And the blood pressure was, I wouldn't say low, but it was at least not high. A high blood pressure could be a clue, as we would discuss further down in the presentation. He was not shocked. He had normal male genitalia. It was debatable whether he had hyperpigmentation or not, but certainly gonads were palpable, and hence it was not ambiguous in any way or form. He had a septic screen given the presentation, though there were no risk factors for infection. As you see, his gas was reasonably all right, but the gas, blood gas, did show the sodium to be low at 100, potassium to be 7. Obviously, it was a capillary blood gas, so potentially a bit of squeeze, but given the sodium is that low, you have to take that with some caution. The lactate was 3.4. And the serum blood test came back with sodium of 104, potassium of 6.9. His CRP was less than 1. He was not hypoglycemic at that time. So given the results, obviously congenital adrenal hyperplasia was one of the differentials, and hence these blood tests were sent, including 17-OHP, cortisol, ACTH, aldosterone, plasma renin activity. And in the UK, we have access to something called urine steroid profile. I think it is not available in a lot of parts of the world, but there are ways, as we discussed in the previous slides, to assess the pathway further. But if it's available, it's a very useful test, and it is important we collect the samples before we start the child on any treatment. Obviously, ultrasound abdomen was requested so that we identify the internal organs, but also the adrenal gland. Parents were white British. They were non-consanguineous in their relationship. So a 10 milligram IV start of hydrocortisone was given, followed by 5 milligram IV every 6 hours. His body surface area was 0.2. We'll discuss the doses if you're unsure of that. He was started on full maintenance IV fluids, and feeds were tolerated, so they were added as well. Obviously, had he presented in shock, we would have given fluid boluses with normal saline, and had he had any hypoglycemia, treating that becomes crucial. So we give 2 mils per kilo of 10% dextrose. His cortisol, which is done in-house in our laboratory, came back quite quickly, and his cortisol was 898. Of course, that meant people thought, is it congenital adrenal hyperplasia or not? Because the cortisol is quite high, and appropriately so in the context of how he is presented. But the caution here is the cortisol assay that we have in our laboratory, which is not a tertiary setting, is not the best of the assays that are available in the world. So it does pick up some other metabolites, the precursors that you saw before the 21-hydroxylase enzyme acts, and it picks up those, and it falsely tells you that it's high cortisol, where in fact it was low. Ultrasound was available, and that was done, and ultrasound showed adrenals to be enlarged. I'm not a radiologist, but I've got a picture. If you're a radiologist, perhaps you can read that. And our radiologist was quite excited to let us know that he has got the diagnosis for us. Literature suggests cerebriform or wrinkled appearance is very characteristic of CAH, and that is a useful sign for your radiologist to differentiate between a normal neonatal adrenal compared to an adrenal which has got hyperplasia due to CAH. And certainly one of the things that you need to rule out with primary adrenal insufficiency in a baby is whether there is any bilateral adrenal hemorrhage. So certainly this was not the case here. And hence his comment was convincing appearances of adrenals suggestive of CAH. So this gave us a quick diagnosis, and it was available in-house. We'll discuss some of the other test results and the time frame it came. So in the next 48 hours, Michael's sodium improved with the treatment that we were giving. His potassium came down. His culture tests were all negative, so antibiotics were stopped. IV fluids were gradually weaned and stopped as he was tolerating feeds very well. His IV hydrocortisone was switched to oral. Again, similar to what Dr. Birrell mentioned with regards to thyroxine, hydrocortisone is best given in a tablet, crushed tablet forms, or now very expensive granules are available, which we give to our patients, particularly those who are very young, because it comes in smaller doses. And then it is important to note that a suspension or a solution of hydrocortisone has got lesser bioavailability orally, and that might impact the dose you give. And you might need to give higher dose if you're using a solution or a suspension. And then subsequently, the dose was further reduced to 2 milligrams 4 times a day. I think the last bit there, 4 milligram QDS is a typo. It was 4 milligrams in a day rather, so further reduced gradually. Commenced on fludrocortisone 200 micrograms daily to provide that mineralocorticoid activity. Hydrocortisone does have some mineralocorticoid activity, but obviously these babies require much more than that, and more so because at that age they are relatively mineralocorticoid resistant. Also, because they are losing salt in the urine, we provide some supplementation, roughly 4 millimoles per kilo per day. And then it's pretty much spread across the feeds that the baby gets. So 17 OHP result came back, and it took 4 days. So it was quite high, 650. Usually it is in double digit or single digit. ACTH was quite high as well, and renin was high as well, giving us a diagnosis, obviously in the context of low cortisol or the signs of low cortisol. High ACTH is suggesting a primary adrenal problem. This is the urinary steroid profile I was talking about. It tells you each of the metabolites in micrograms per 24 hours. And it's a very useful test if it's available, non-invasive, and particularly useful if, say, for example, serum hemolyzes and you lose the critical sample that you needed to make the diagnosis, then at least that urine is available for the biochemist to look at. And they often give very helpful comments at the bottom. As you see, CAH due to 21 hydroxylase deficiency is confirmed by a characteristic pattern of excess metabolites. And as you see, the metabolites above are virtually absent if the baby did not have that enzyme defect. So they pick this up and that result is available. But the only problem there is it took 3 weeks in this baby, despite us trying to make it done quicker than usual. Obviously, CAH is one cause for primary hypoadrenalism in a baby. There are other causes. One of the causes I mentioned was Smith-Lemli-Opitz syndrome. As you see there, it comes under CAH as one of the causes of CAH. There are other causes like congenital adrenal hypoplasia, autoimmune disorders, and of course, rarer metabolic disorders, particularly adrenoleukodystrophy and Zellweger syndrome. This I won't be covering in this talk, otherwise I'll be talking for hours. So I'll just move on. But I think in resource limited settings, ultrasound is a very good investigation, particularly because there are appearances of adrenal glands, particularly if it's bilateral with the wrinkle cerebriform pattern that I mentioned. And it also rules out adrenal hemorrhage as a cause, but also it looks at Mullerian structures in genotypic female. If you have a baby with ambiguous genitalia, then it is important to look at that as well. And then it rules out any renal anomalies associated with other differentials. So it might be worth, if you don't have access to a lab facility or for that matter, urinary steroid profile, that you speak to your radiologists beforehand so that they also develop their skills at looking at babies' adrenal glands. So they are prepared in case a baby comes, so they do that and they are able to guide you in the treatment. So in terms of management, we offer genetic screening for all children and their families to provide genetic counseling, as well as recurrence risk in terms of future pregnancies in the mom. Hydrocortisone dose is 10 to 15 milligrams per meter squared per day, a bit higher than what all of us need, and that's basically to reduce the ACTH. And if you reduce the ACTH, you reduce the adrenal androgen production, and that's the main focus of management initially and subsequently as well. We'll discuss how doses can be adjusted in the later slides, but generally we give 4 divided doses in the first year of life and then 3 divided doses subsequently. Fludrocortisone dose range is 50 to 200 subsequently, but sometimes it can be given up to 400 micrograms. It does have some glucocorticoid activity. So for every 100 micrograms that you use, you need to add 1 milligram to your glucocorticoid dose in terms of your milligrams per meter square per day calculation. Renin often remains high in the first 6 months because of relative mineralocorticoid resistance, and then it starts to gradually fall. And of course, aim for normal blood pressure and electrolytes during this time. Sodium chloride is gradually weaned and then stopped at 1 year of age if the renin is normal at that time. 17-OHP profile is done usually 6 to 12 monthly, and that's a good way of looking at which dose you need to adjust. So what we have in the northeast of England is similar to the blood spot that Dr. Bilal spoke about with regards to the congenital hypothyroidism screen. You have blood spot, which parents do. We train them, and they take a spot just before the dose in the morning and 2 hours afterwards, and similarly for other doses. And then we look at the 17-OHP in each of those blood spots, and that helps us guide whether we need to change any of the particular doses. Of particular importance is the last dose of the day, so that overnight there is enough suppression of adrenal androgens. And of course, in the morning, because they need to have sufficient cortisol around, and hence you need to ensure that the 17-OHP is suppressed. And that suggests the risk of adrenal crises happening again is less. Emergency treatment, oral stress dose, less than 5 years, we use the morning dose and we multiply by 3, and then we give that every 6 hours. And the morning dose, we say, because the morning dose is the biggest dose of the day. So the way we split is not equal throughout the day. We give the morning dose to be the biggest dose, usually 1/2 of the dose. More than 5 years of age, we just multiply by 2 to the maximum of 20 milligrams per dose, 6 hourly. Obviously, all parents and carers are trained to give intramuscular hydrocortisone for these children in case they are unable to tolerate orally. And the dose is, as you see, 25 milligrams under 1 year of age, 50 milligrams between 1 and 5, and subsequently we use 100 milligrams. And all of those children would then need to come urgently to the hospital. And if they do, they have an emergency healthcare plan. And the IV doses, as you see, usually we use 100 milligrams per meter square per day as IV. We prefer to divide that into 6 hourly dose of hydrocortisone given its short half-life. Continuous infusion also can be used, but you run the risk of the cannula getting displaced and the child not getting the dose correctly. The treatment principles are, one, we have to make it very clear from the outset that the treatment is lifelong, and certainly parent and carer education from the outset is a very good investment, and it is of paramount importance to keep the child safe. What we need to consider is to use the lowest effective dose rather than just by going to 10 to 15 milligrams per meter square of glucocorticoids. Because if we just concentrated on that, we might be overdoing rather than doing it correctly. And of course, the lowest effective dose of mineralocorticoid also should be chosen. To reduce adrenal androgens is the main idea there, and to normalize electrolytes and optimize growth and skeletal maturation. Parent education, as I discussed, they should know when they should need to increase the hydrocortisone dose. There is some international guidance available on this, and it highlights the need to do this in significant intercurrent illnesses, particularly those involving fever, gastroenteritis, and dehydration, major surgery, or trauma. Less minor illnesses like daily stress, physical exercise, they don't need increasing the dose. If children or young people or parents are doing it, then we need to see that that's what they're doing, and we need to redirect that through education as to when they need to increase the dose. Children should wear a medical alert bracelet or a necklace so that bystanders are aware of this being the reason they might be unconscious. Intramuscular hydrocortisone should be always available with them, and then parents and other carers are taught within our service to administer this themselves rather than relying on any healthcare professionals. Obviously, a good emergency healthcare plan is important for our junior colleagues in the hospital for inpatient management should the child come to the hospital. Monitoring, 3-monthly follow-up until the age of 18 months, and then 4-monthly subsequently is required. At all visits, height, weight, height velocity, BMI, blood pressure are required to be calculated and measured. Biochemistry, we measure sodium, potassium, 17-OHP. It's not required at all visits, but certainly to be considered. Renin and cortisol and androgens, again, not at every visit, but needs to be considered. So some of the signs of under and over treatment, because what you're doing is replacing what the nature is not producing, and we are no match to nature, and we need to closely watch what we see and change our tactics so that we deliver the appropriate dose. So the signs of under treatment are similar to the time the baby might have presented, including tiredness, collapse, shock, hypoglycemia, hypotension. If it's little under treatment, then it could cause progressive virilization. Obviously, height velocity increasing quickly is another sign because of skeletal maturation coming from adrenal androgens, which are getting aromatized into estrogen. And as you know, estrogen is the one which causes skeletal growth. And again, we need to consider some blood tests. Again, 17 OHP profile is good. Obviously, if it is high at any point, it suggests inadequate dosing. High androgens could also be one of the ways you could find out. Over-treatment, again, that's easily missed compared to under-treatment because of worldwide obesity epidemic, particularly in children. And hence, what you might see is they are getting overweight, and hence weight determines your body surface area, and that determines your dose, and hence you might overdo it, thinking that you're doing the right dose. So you got to be careful there. You got to watch out for Cushingoid features. You got to measure the blood pressure so that you're not missing high blood pressures in children. Obviously, they are gender and matched with height centiles. So that's a bit tricky to do every visit, but it's so important to keep an eye on. Height velocity, again, a reduction in height velocity is one of the key ways it gets picked up usually. Again, high cortisol levels or 17 OHP profiles, which are absolutely suppressed at all times, could also show you that that is what is happening. And again, with mineralocorticoid being excessive, you might see that the sodium and the potassium is also getting affected. So in general, if you look at the overall management of children with congenital adrenal hyperplasia from birth to 8 years, the important thing is early diagnosis and gender determination, particularly in genotypic females, as we will see in later slides with regards to psychological effects on them. Surgical management is a controversial topic, whether to do it early or late. I don't think the jury is out on that, so it's something for discussion with parents. Growth and development is an important determinant of your management, as well as prevention of hypoglycemia and crises. In the middle childhood time, obviously growth and development, puberty, adherence to treatment, as well as psychosexual features. And over 16-year-olds, certainly concordance with treatment is an important factor. Girls can present with polycystic ovary syndrome, hirsutism. Certainly the non-classical ones is one of the ways presents. Fertility is an issue which sometimes is not an area of focus for young people, but that is something which we discuss closer to the time that they are reaching transition age. Adrenal rest tissue is something we find in testicular in the testicular nodules that we sometimes examine and find. What you get is a testes which is not in keeping with the child's Tanner staging otherwise, but has got nodular feel to it, and you do ultrasound scan and you see adrenal rest tissue. Basically, it's adrenal cortical tissue within the testicular tissue, which is pretty much causing pressure effect on the rest of the testes, and eventually leads to infertility in young men with CAH in the background. Obviously, metabolic syndrome as well as cardiovascular implications are there. That in the recent studies seems to be less of a problem. Osteoporosis, certainly if we have overdone it, then steroid effect will still cause osteoporosis. As you see at the bottom, it's a multidisciplinary management, and certainly the key focus is the child, young person, and their family. And then a good transition service is key for their subsequent good health and reducing the rates of infertility. Psychological issues, certainly without any doubt, if young girls have got ambiguous genitalia, they've required surgeries, they've stayed away from their usual settings like schools or nurseries, then you're pulling that time away from usual activities. So they eventually go on to develop poor self-image due to virilization. Short stature is a factor, increased weight, hirsutism, and studies have shown, particularly females, avoid having sexual interactions, and there is that risk of there is that increased incidence of them avoiding sexual interactions and pregnancy. And of course, if they do, then their chances of falling pregnant is also reduced. Social withdrawal and stigmatization is certainly an issue. So it will manifest at some point, but it is our role to pick this up early and seek support for them. In terms of new trends of management, this has been an ongoing debate whether 4-drug management is better in terms of glucocorticoid, mineralocorticoid. You can also add aromatase inhibitor, so it reduces estrogen available and hence slows down the skeletal maturation. And of course, androgen blocker to avoid virilization, further virilization. But it's not come in routine practice as yet. There are suggestions of using hydrocortisone pumps, particularly from Great Ormond Street Hospital in London, because of some individuals having rapid clearance of oral hydrocortisone. In them, hydrocortisone pumps might be an answer. Also, modified release hydrocortisone, something which has come in the literature. A few slides about non-classical CAH. It presents late in childhood or early adulthood and manifests with premature adrenarche. If you ask me, do I send urinary steroid profile for each child with premature adrenarche that I see? I don't usually, because sometimes I end up doing 17 OHP in the 8 o'clock morning sample. And that itself gives a fairly good idea whether I'm dealing with this. Obviously, I follow them up and look at their height velocity. And if I'm concerned, then I certainly go ahead and do it. Of course, it's available to me, but it may not be available to you. And in those situations, you can consider doing a cosintropin test and looking for response with 17 OHP. And as we saw that graph, it might help you to find out non-classical CAH. Again, advancing bone age is one of the factors that you might see when you are considering non-classical CAH. Girls, certainly polycystic ovaries syndrome, you need to consider that as a possibility. Oligoamenorrhea is one of the ways it presents, certainly with acne, androgenic features, basically, and insulin resistance associated with this. About 5 to 10% of children with premature adrenarche have this, so not all. So choose your investigations when you see them. This picture I put just to highlight in boys particularly. In girls, it's very easy for us to think about it. But in boys, it may just present with enlargement of the penis with some pubic hair development, but very prepubertal size testicles. And that's one of the key features that you might see with non-classical CAH. Obviously, they can present with greater height velocity, and that might be the reason that they've been referred to you in the first place. But certainly, if you see a peripubertal boy, but with prepubertal testes and large penis and pubic hair growth, then you should consider non-classical CAH. At the time of puberty, this is a good tabular column for us to think about. Classical CAH, if they are abnormal, as in they are not having a good concordance with your treatment, if you look at this chart, if you have 21 hydroxylase deficiency as a genotypic female, and then they're not taking their medication, so what happens is this progesterone increases. So as you know, progesterone is one of the ways of contraception, and it also reduces your hypothalamic pituitary ovarian axis, so they don't go on to develop into puberty. So puberty might be delayed, so no thelarche, no menarche, or if they did, and then they can develop secondary amenorrhea. So pretty much like being on medroxyprogesterone all the time if they are not getting adequate amounts of treatment. Cystic ovaries in boys, as we discussed, small testes, and that is not just the problem. Obviously, decreased spermatogenesis and decreased fertility in them is a real issue. which might not be their focus at that time, but may be their focus subsequently. If they are treated appropriately, what you will find is they go into puberty correctly, they have no problems with infertility. With non-classical, as we discussed the features, in boys, cystic acne and premature adrenarche is one of the ways it presents. So this chart again, the reason I put it is because we'll just have one slide on other causes of CAH. Busy slide, but what I want to highlight here is in 17-alpha hydroxylase and 11-beta hydroxylase, they often present with hypertension at the outset. And the reason for that is, so 11-beta hydroxylase is a defect here. So what you find is deoxycorticosterone and 11-deoxycortisol is the precursor molecule, and that increases in its amount because it cannot go downstream. And that has got, this deoxycorticosterone has got mineralocorticoid activity. Deoxycortisol, not so much of glucocorticoid activity, but this is available. Cortisol, not so much. Hence, the ACTH is still getting produced because of lack of negative feedback. And hence, the pathway gets diverted mainly this side to deoxycorticosterone, as well as onto this side to produce adrenal androgens. So what happens is they present with ambiguous genitalia in a genotypic female, but also with hypertension and potentially not hyperkalemia, but hypokalemia and hypertension. And of course, the other forms, which is 3-beta HSD, you have ambiguous genitalia in XY genotype. And the reason for that is 3-beta HSD is a enzyme which is required in the testes to form testosterone eventually. Without that, it's the most proximal enzyme in the pathway. Not much testosterone is produced, but DHEA, which is here, is a weak androgen, and hence boys, genotypic boys, are not adequately developing their genitalia, and hence it's an ambiguous genitalia in XY genotype. And then obviously in 17-alpha hydroxylase, what you don't see is any virilization. And the reason for that is the defect is here, and hence these pathways are working, but none of the adrenal androgens are produced. So the female genotype produces a female phenotype without ambiguous genitalia. I think that concludes my talk, and thank you very much for listening.
Thanks.
Dr.
Yeah. Thanks, Dr. Kishore. I think for question, I will forward to Dr. Anil. Yeah.
Right. Thank you, Jeannie and Kishore, for the excellent presentation. It was very, very informative. I myself learned so much today. Yeah. There are quite a lot of questions. I didn't expect that this many questions will come, but yeah. Shall I start with Kishore at the moment? Yeah.
Yeah.
There's a question like some cases of CAH on treatment with adequate dose of hydrocortisone in higher side, but still 17 OHP very high, more than 40, and cortisol low. Otherwise clinically stable and electrolytes normal. What should we do?
So, I mean, it would be important not to just determine one of 17-hydroxyprogesterone, but to determine at various times during the day, so that you are able to adjust the dose at particular times of the day. That would be my first suggestion. Again, one of the reasons it might be elevated is lack of concordance. And of course, the other reason which I mentioned is use of suspension and solution, which has got less bioavailability. Because if you look at previous guidelines, and many a times you would find that the dose mentioned is up to 20 milligrams per meter square per day. And that's relating to older formulations of hydrocortisone. So it could be the formulation, it could be absorption issue, it could be the patient themselves, or it could be the dosing schedule that we are using. Of course, if it's still not coming down, then phone a friend, call a tertiary endocrinologist. I'm sure they'll be able to help you.
And of course, I think you have answered this question. How frequent should we check 17-OHP and renin for monitoring?
Yeah, 17-OHP, generally 6 to 12 monthly. We usually go for 12 monthly, but the clues are already there before even you see it. Often it is helpful in those who we think we perhaps have given too much of a dose. And then you see very suppressed 17-OHP all through, and that also adds to your assessment. But generally speaking, 12 monthly. Renin, obviously, you reach a steady dosing schedule around the toddler age group, and then you can do it once every 6 to 12 months again. Of course, if they have hypertension at any point, or their electrolyte is have got imbalance in that, then you should consider that point as well.
Okay. Yeah, in one of your cases, the Michael, you said that in that case of Michael, with blood report of hyponatremia only and confusing genitalia, can we label the case as CAH? If all those other tests are not available? I think this is from the South Asian part.
Yeah, so in the context, certainly you should try and look for common things in babies, which is sepsis. Sepsis, that's potentially how it may also present, but certainly sepsis and syndrome of inappropriate ADH should not cause the sodium to drop so much, one thing, and certainly should not cause hyperkalemia. And of course, if there is ambiguous genitalia, you're already in that territory of differential diagnosis, so you should consider. And more so, giving hydrocortisone in a baby you're not sure in that context of hyponatremia, hyperkalemia will absolutely do no harm.
Okay. And somebody has also written that, what is the sensitivity and specificity of ultrasound showing wrinkling appearance of adrenals in CAH? To diagnose CAH?
I think the way to be honest, I don't know the answer. But the way I look at it is, I work in a DGH setting. We don't have access to some of the investigations that quickly that a tertiary center might have. But within what I have, I think this is a good investigation. If it is showing something, then it helps you. If it's not showing something, it does not rule it out. It could be the person who is doing the scan who is inexperienced in looking at baby's adrenal glands. So if it shows you that the adrenals are hyperplastic and big, then within the context of what you found in the baby, it fits in, and that helps you as well.
And of course, you have answered this question. When do you suggest surgical management in viralized baby? I think you have answered.
Yeah, it's a bit of a controversy as to because what happens is if early management is done, then the subsequent surveys have shown that it reduces sexual satisfaction in girls because all the nerves are affected, and there is some refinement in surgical management, but it is not come out in a clear guideline when they should be offered surgery. Obviously, then it falls in terms of discussion with parents as to what you're trying to achieve, and what is the outlook subsequently. And we should give all the information to parents, and they should come to a conclusion with our help, but with some informed consent towards that procedure.
Okay. Yeah, I don't know whether this is a question to Ginny now. There are quite a lot of questions on thyroid which came after you left. I'm not sure whether you'll be able to answer this question, but how can pediatricians do in the absence of screening programs? I think this is from South Asia.
I think that's a really good question and difficult to answer.
Yeah.
I think that if screening programs were initially started within cities, within areas where there are better resources, and been proved to work and show the evidence, then the next step would be to look at how you spread that out through a community. But I think to start with, it would need central funding, it needs government support, and using the evidence that we have from the UK about the benefits of screening and the reduction in children with developmental problems would be a place to start. So I would think you've got to start somewhere, and I think getting started is the hardest step. But the evidence is there that it works. Start it in a city, get things set up locally, and then look at how that can spread, and use the information and experience that we've had in developed countries, in you know, the USA with the UK and much of Europe. Take that forwards and see how things go.
Yes, we have Dr. Bista as the president of Nepal Paediatric Society. I think he can take this forward to the government in view of starting the screening program in a small scale, then use it widely, because the literature I've seen from South Asia most of the time is these congenital hypothyroidisms are diagnosed whenever they come to hospital only. There might be quite a few who are undiagnosed walking around in the street. Yeah.
So now we have Southeast Asia Paediatric Association of containing Nepal, India, Bangladesh, Sri Lanka, Pakistan, and Bhutan and Maldives. So in this forum, we are also talking of South Asian Alliance for congenital screening of hypothyroidism. I don't know how we'll be able to do it, but it's a talk is going on. So for all 5 countries to do as possible. Yeah.
There are quite a few reports when I was going through. Most of them are diagnosed at around 3 to 6 months. So by the time you would have missed a boat. Then the brain growth, development, all these. Okay. There's another question, Jenny. Like mother is hypothyroid. TSH in a baby is between 10 to 15. Should we repeat the test or treat?
I would look at the T4 and the T3 as well before any treatment. I think 10 to 15 is a bit more borderline than once you get above 20. And most people would say if you've got a normal free T4, T3, if it's between 10 and 20, you can probably afford to wait. But if you've got a low T4, T3, I wouldn't hesitate. I would start treating. So it gets on. I think that's the reason why it's useful to have a single paediatrician in each centre who gains the experience of these cases, rather than disperse these amongst general paediatricians. Okay.
But somebody looks like it's from the UK. The ADHD and behavior issues marker of overactive thyroid. Believe me, this would mean a lot of children to test, especially during this pandemic. I would not have considered BT in this group. Is this fairly common?
No, I don't think it's common, but I think that if you've got a child with ADHD, you could actually examine them for tremor, for sweating, for tachycardia, for a goiter, and think about it and start looking at patients' necks. And I think if there's no other clinical features other than the child is fidgety and on the go, then you probably have got ADHD. But when you've got that with the other features, so my encouragement would be a good examination and a good clinical history, and then to screen the ones that you're not sure about.
Yeah, that's right. Okay, Kishore, this is for you, I think. Well, what type of medical legal problem may we face while dealing with a baby with 21 hydroxylase deficiency CAH?
It's a broad question.
That's right.
You could face an array of problems or none at all. I'm not sure how to answer that.
Yeah. Well, anything late diagnosis, all this, isn't it? Yeah, especially
as I mentioned, boys with CAH present with salt losing crises, and if we don't do, or say for example, a blood sample for urea and electrolytes gets hemolyzed or something, and we don't check sodium and the potassium, we might just think the baby has got sepsis. So it's kind of being aware that this is one of the differential diagnoses in a baby presenting like that, because mortality is a real possibility in boys presenting like that.
Okay. I think this question is before you put up last few slides. If oral hydrocortisone is not available, what drug can we use?
People use prednisolone, but I'm not seen in UK we using it in younger children. We have used in late teenage years because that's the only way we can get some concordance in them. And I think, to my knowledge, hydrocortisone is pretty much available throughout the world, and it's quite cheap and available.
Is it readily available, Dr. Bister, in Nepal?
Yeah, I think it is available, but difficult to say readily. It's available, I think.
All right, okay. The problem in diagnosing like CAH in resource-stricken countries, especially when you don't have a proper healthcare facilities, is they are being treated as a gastroenteritis. Yeah, and when they land up into the hospital, they are in a moribund stage. I saw before coming here like one or two cases like that where they are severely shocked, and they are nearly in like a decompensated shock before we could do anything. So that's the problem. I think the awareness of this program is very, very important, I think, in diagnosing these conditions. Okay, any other questions I've missed? I think these are the questions. And anything else that you both want to say, Kishore and Jeannie, at the end? I think, well, I'll just conclude then that thank you very much for your excellent talk. I learned myself so much from today's talks. And the thing I think we can take from today's talk is how to develop the screening program for this very, very treatable condition in resource-stricken countries. I think Dr. Bister will take this forward to the Nepalese government, right?
Yeah. Thank you, Dr. Anil. In Southeast Asia, in Sri Lanka, there is from 2006, they are doing screening. I think it's all over the country in Sri Lanka. I think other than Sri Lanka, I don't know, there are screening program in Southeast Asia. So there was a talk on screening on hypothyroidism on IAP conference yesterday, and it's a very good in Sri Lanka. But I don't know in other region there is no any screening program. We wanted to do a research on screening, but it was quite costly. We were not able to get a fund.
I looked at it all.
We planned around 2,500 samples all over the country, but it cost more than crore rupee. So we are not able to get fund. And
for 2,500, 1 crore, is it?
Yeah, because it have to collect it. It's not done in Nepal.
All right.
We have to send it India. So, and we have to from different parts of the country, not only from Kathmandu, eastern, western. If we do whole country, and so we have to get samples from all country, and so it's difficult to transport also. That will cost us a lot of money. I think we have to send from it's a Madras or Chennai, just like that. There is their lab, big lab. So it's quite costly to send. We were searching fund for that last 2 years, but we are not able to do.
Okay.
So no, we are now we are trying for screening, but let us see. We'll talk with government also.
Yeah. Okay. We'll follow that up, January. Yeah. Okay. For the audiences, please kindly fill up online evaluation form. Yeah, you are not going to get certificate till you fill that up. Yeah, there's an online form. All of you can access it, and you'll be sent a certificate. And in the end, I'm really, really thankful to HExN UK, our pediatric department at James Cook University Hospital, Nepal Paediatric Society, and Myanmar Paediatric Society for their support. And to the USP in India, who has really helped us in publicizing and making this event possible. And it's a major task to telecast this to all the 4 or 5 countries in the Southeast Asia. Thank you so much anyway.
Thanks everybody.
Yeah,
So I
thank
think
you.
we will meet after
Thank you,
2
sir.
months. Yeah.
Yeah. Thank
So
you.
we'll
Thank you,
do-
Thanks
everybody.
everybody for connecting, and thanks for
So we have
it was
Dr. Amit
excellent
also
lecture.
with us. He
Sorry?
has joined. Dr. Amit has joined from USV.
Okay.
Dr. Amit.
Yeah, hello.
Yeah.
Good evening, sir.
Hello, hi, Doctor. Yeah.
Yeah, hello. It was great presentation, and it was like great insight from everyone about various conditions. And thank you for your valuable time and involving USV as your partner in conducting this event. Thank you very much.
Thank you. And that's really
Thanks everybody.
helpful. I tell you, we are really indebted to your help and support for bringing this up. Yeah, thank you.
Thank you, sir.
Thank
Thank
you.
you, ma'am. Thank you, sir.
Thank you. Thank you.
Thank you.
Thank you. Bye.